Well, it turns out in the 1970s, it was known that if you had low-dose organophosphates, depending upon the specific agent, you would develop what's called chronic organophosphate-induced neuropsychiatric disorder. That was this paper from 1971, American Journal of Medicine. So it's not really classified, but it seems nobody knew about this. No neurotoxicologist, nobody at Walter Reed, nobody that has ever come forward or has reported has seen this. And what are the symptoms? Delayed effects, weeks to months later. Fatigue, drowsiness, confusion, chronically depression, irritability, cognitive problems, sleep, chronic fatigue syndrome, GI problems. Is it sounding familiar?
Yeah.
So let's look at the pyridostigmine bromide. I think it was really a good attempt to keep people from dying. 1986, though, there's this paper that shows that if you expose rats to soman or sarin, they become super sensitive to atropine, which is used as one of the antidotes for organophosphates, nerve agent. So they give soman for 3 weeks, and what happens is the receptors in the brain become exquisitely sensitive so that now the atropine is causing adverse events. This system is being affected, and I think it is possible that low-dose exposure throughout the month of January and February combined with pyridostigmine taken orally could have exacerbated the neurotoxicity. Leela, we got a grant to write. So what happened when the soldiers came back? Nothing happened?
Well, I did a sense of no help and see you goodbye.
No.
Thank you.
Anything for us.
They start kicking people out. Draw down.
Yeah.
Sir?
Well, they had what, and I participated in that. It was a Pacific Gulf a study. Basically, a lot of people on active duty started complaining about health problems. So the DOD put together their version of, trying to figure out what's wrong with all these people on active duty. Well, now the problem was if you kept on complaining about it, kept on going to TMC and so on, they were doing a drawdown. So that kind of put you on the bad boys list. Next thing you know, it's like, okay, time for you to go. So a lot of us decided to, like myself, who intended on making, having a military career, doing 20 years or so, we just turned around and just shut up about it and don't say nothing.
Okay.
We didn't want to get kicked out.
So did any of you have an organic disease? Did you have a disease?
No.
A disease. You can see a lesion. You can see an x-ray change. You can see a blood test.
Yeah, a lot of us had disease.
No. So what happens? The body here was not affected. So if it's not your body, what's wrong?
Mine.
Mind. You got that mind-body dualism.
Yeah.
They ran tests on me for the neurological problems and it came out.
Oh, special case. Did it get reported?
Yeah.
Where?
The Army found it and the VA denied it.
It's all in your head, Jim. Did you get PTSD from getting denied?
No, I got VASD.
So we're laughing, but in the first study we did, I would say 25% of the people complained of PTSD-like symptoms when I brought up the VA, and they brought up their treatment. This is something the VA has to reconcile itself about and plan for the future about who is the patient, who is the customer, who do you believe? So where did this mind-body dualism come from? You guys know René Descartes?
Yeah.
Okay.
I know him.
Who took geometry, X
Never
and
put-
Y axis?
Never put the cart before the horse.
There you go. He's the guy who separated mind from body. In his first iteration, he felt the body was a machine, and physics was the highest form of science at the time. So this represents the mind. And here we have the soul, which was inspired by theology. The two systems talk through the pineal gland, and messages are sent to your body through the cerebral spinal fluid, which I study intimately and hope to report to you later if I have time, and through these wires that go out the peripheral nerves. He later, as many people do, recanted on this theory. However, cat was out of the bag, and other people picked it up, and by the turn of the 1900s, this had evolved into the separation between medicine, surgery, and psychiatry. So, from Rakib's work, it's clear what we need to do is put René Descartes back in the box. We need to connect the brain as another organ that can have diseases. And you have brain disease that we need to think about, localize, and identify so that we can understand the mechanism and figure out treatments. We got to put the black box back in the body. Here's an example of organophosphate poisoning of the mind, not the brain, right? This is someone who had that neuropsychiatric syndrome. In East India right now, there's a real problem with farmers committing suicide using organophosphates. That's all they have available for committing suicide. If they commit suicide, their family gets a large payment of money that allows the family to buy the farm and survive. So there's often a lot of pressure on the farmer to commit suicide to save his family. There's a lot of cases, I'd say, outside of Iran. Most of the cases that you'll find will be in India. Does anybody know what these two white spots are here? Rakib? Basal ganglia. And where do they light up? Where? In their stop group. So this is probably totally unrelated, but it makes us think that we have a potential explanation for why our stop group lights up their basal ganglia, this important area in the brain. Okay. We've heard the epidemiological symptom salad, and that's been extremely valuable because it's a start on being able to define who has Gulf War illness. Because, of course, we don't know, because we don't have it, right? And we can't take your word for it. So what are the Lee Steele Kansas criteria? Just to reiterate what was said this morning: fatigue and sleep problems, pain symptoms, neurological, cognitive, mood symptoms, gastrointestinal, respiratory, skin, and then a mixture of other symptoms. You have Gulf War illness if you hit 3 out of the 7 on the list. These were pulled together without an understanding of how these symptoms fit together in terms of pathology. So that's what I'm going to focus on here for the rest of the time, is how can we pull these 44 symptoms together into something that's a little bit more logical and treatable. And I'm going to do that by comparing Gulf War illness to the overlap with chronic fatigue syndrome, fibromyalgia, and depression. You're all familiar with Venn diagrams?
Yes.
This is the differential diagnosis of Gulf War illness. In red, you can see the symptoms of Gulf War in the center. Then we've got fibromyalgia. Down here, we've got chronic fatigue. And over here, we've got depression. Got it? We'll come back to that. So Rakib introduced you to our model, which we came up with by having people fill out, what is it now, 40, 50 questions in our questionnaire beforehand. Who's taken part in our studies, by the way? Okay. How many questionnaires did you have to fill out? It's about that many. Come in, do an fMRI with a cognitive test. You have exercise, and unlike Nancy, we're doing a sub-maximal test. And that's because that's sufficient to cause a cognitive change, and in general is reproducible on the 2 days without causing a severe exacerbation of symptoms. We compare blood work, cognitive autonomic function before, after. Rakib's discussed the start-stop reversible tachycardia we get afterwards. We do lumbar punctures. We have a group that had them done at rest, before, without exercise, a group that had them after. We're now comparing the proteomics, the metabolomics, the messenger, the microRNA patterns that are there. And then we followed people up afterwards. So, taking the Steele criteria, you can shift these around into something that's a little bit more logical. We have the symptoms of exhaustion, including post-exertional malaise, exertional exhaustion, the sleep abnormalities. A big thing that comes through from talking to the participants in our studies is threat assessment. Threat assessment is critical to our survival. But if a knock on the door is perceived as a life-threatening threat, that's not good. It might just be a girl guide selling cookies. That works through a part of the brain called the amygdala that is, in a way, a fear center. The cognitive dysfunction, Rakib showed some data, and I'll elaborate on that a little bit. A very important thing is systemic hyperalgesia, or tenderness. Is anybody here tender? Like me? Do you know what tenderness is? You have pain, which is the symptom you tell me about. Then if I come at you with my spring-loaded gauge and press it against you, you will tell me if it's sore. That's called a sign. I'm doing something to cause you to feel pain. That sign is tenderness. And systemic hyperalgesia is the fancy name for it. You have different sets of nerves that come from your skin, give you cutaneous information, your eyes, and other senses. You have your muscle and joint senses, and you have your interoceptive system. It goes from your nose, eyes, down through your lungs, gut. I'll show you some of the suggestions of how this concept of sensory nerve dysregulation may play a role with your symptoms, including respiratory and gastrointestinal, although I think there's, especially with the gastrointestinal, there's something peculiar there. The skin, mouth, it would be great to biopsy those lesions and get a systematic idea as to what those little black dots are, what those red blisters are. This is for the doctors in the room. This is the first CDC scoring system that came out. I've modified it by, instead of asking for a yes/no answer, do you have these, to asking you to scale it. None, trivial, mild, moderate, severe. That gives us both an idea as to what the worst symptoms are, how relevant they are to you. I can sum these up, and we'll do that now that we're in our data crunching phase. With the Steele criteria, oops, okay, sorry. We have a new form like that for the Steele criteria, and it'll get published in about 2 or 3 weeks, hopefully. Anybody who wants, I'll send you a copy of the paper out. It's embargoed right now, so I'm not allowed to talk about it. At the end, I'll give you an email address. If you would like a copy sent to you, just write down our address and email us. So here's kind of the key findings for Gulf War illness that I had mentioned before in the bigger, more glommed up Venn diagram. These are sort of core symptoms that conveniently overlap with other syndromes. Oh, there it is. There's my form. So this is all the Lee Steele symptoms. None, trivial, mild, moderate, severe, year of onset. And then just as your points were, did you have onset in theater? Of course, I just have to believe you because you don't have any documentation, do you?
I do.
Jim, you're always difficult. Okay. So the exhaustion part, it's basically fatigue, exertional malaise, the sleeping components. For the cognitive questionnaire, for the cognition, Rakib showed some of the two-back working memory results. I'll show you some more in the next slide. And we also discovered that out of our battery of 40 questionnaires, we could come up with 12 individual symptoms that were separating at first. It looked like our stop versus our start people, but now that we have larger numbers, it clearly separates Gulf War illness from our control population. Controls score about 7 out of 43 on this scale. The Gulf War is about 14, but it's very skewed to the high numbers, so that actually, I think it's higher than 14. And please imagine that there's the diagram here that I spent all week drawing for you. I forgot to send. Anyway, this cutoff of 12 picks up 80% of the Gulf War illness people and excludes 80% of the controls. That's actually pretty good for a screen. Here's the results from the working memory task. So we do a series of these. First, there's a zero-back task. That's where you see a letter and push a button. That's just for attention. In work that I can't show you right now, we're able to show a difference in the connections between different areas of the brain, between the controls, the start, and the stop group. That's the functional connectivity, just looking at a letter and pushing a button. No memory involved, just attention. This is working memory. I'm going to tell you a letter. I'm going to give you a string of letters. I'm going to tell you, I want you to remember the letters as I say them, and then shout back at me the number that is 2 back from what I just said. Okay, you ready? A.
We know what that is.
B. D. C. A. D. F. Okay, are you sure?
No.
Okay, so I got 28% on that. First time I did it. It's humbling. This is a hard task. So we let everybody practice, and you can see the controls in general score above 80%. Except for this guy who said he didn't try very hard when he was in the scanner. And this guy who's a low control, and it turns out there's a genetic subset who scored low on this task. Here's our Gulf War illness group. Don't worry
Wow.
about the increase or decreaser part. The message is they scored 60% on both days. That is to say that they did worse as a group on the first day. And even though things went up and down, the net effect was no net gaining training. No training effect, no learning effect. What about threat assessment? It now looks like about 50% of our veterans have PTSD, meeting the 2013 criteria. The important thing about PTSD is it's no longer considered to be depression. It's no longer part of that picture. You have to have an event. It has to be followed by a series of 7 different types of symptoms, and you have to meet those criteria to have PTSD. I would encourage every one of you to ask for a PTSD evaluation. Talk to somebody who knows how to diagnose it, because there may be symptoms of anxiety you have that are going unrecognized. It's not depression. When you see a threat, the first thing you do is freeze. Next thing you do is either fight or flight. You're all familiar with those 3. Not so familiar is the next one, which is faint. This was discovered by a VA psychiatrist in Honolulu studying firefighters and Marines. The bigger they are, the harder they fall. Hey, how you doing? With these guys, you pull out a needle, they're the ones that fall over and pass out. And when they pass out or fall down, they may be awake but almost rigid, or unconscious and floppy, like they're dead. And it's thought that in evolutionary terms, this is essential. If your position's being overrun and you play dead and seem like you're dead, maybe the battle will move along or the bear will move along and just leave you behind to recover. Funny thing is that many of these symptoms are also consistent with this organophosphate poisoning. What about depression? Well, depressed is one of the 48, but it's led many investigators to believe that depression is part of Gulf War illness. And now you guys filled out all those questionnaires about depression, and they will show that you have depression, as I show in the next slide. However, if you go and interview specifically for depression, only about 3% have have depression. The reason is you have to be both depressed and lose interests. 1990, you needed to have thumb pressure-induced tenderness. You would press with your thumb at 18 locations on the body, and if the person had pain at 11 of those, then it was fibromyalgia. In 2010, that all changed, though. They got rid of the touching of the patient. Well, you don't have to wash your hands then, right? You can speed them through more quickly. Just have them fill out a questionnaire. And in fact, in 2011, it's the same questionnaire that they improved to speed people through, but now you didn't even have to see the doctor. Just fill out the questionnaire. How many areas give you pain? Do you have fatigue, sleep, cognitive problems, headache, cramps in your abdomen, or depression? Not that I'm a cynic or anything, but this was pushed by people who are lobbying to support failed antidepressants for the treatment of fibromyalgia. They don't improve the pain, but if you've got a questionnaire that you score that includes depression, maybe your questionnaire score will get better. Like I said, I'm a cynic. So the overlap with fibromyalgia is you take all of these out.
I'm so sorry to interrupt.
That's okay, you can
I
turn the
know
slides
that-
off.
I know that we probably want all day to hear more from you, but I do want to make sure that we have time for our question and answer panel from you all, from the experts. So, we have
The last slide, and so it's gonna have the email, the address to send it in. The email. Thank you.
yes, please come on up. We have our, about half an hour. We have one more hour for our formal program. I'm sure that you'll want to ask questions after that offline. But at this time, I would like to welcome up our panel members. We have Mr. James Bunker, Executive Director of the nonprofit National Gulf War Resource Center. We have Dr. James Berenick, who you just heard from, Dr. Nancy Klimas, and Dr. David Goldsmith. And finally, Dr. Layla Abdullah, GWI researcher at Roscam Institute in Sarasota, Florida. So I will just raise your hand, I'll bring the mic to you, and the floor is yours. Who has questions? Yes, ma'am.
So this is just a very quick question. It's probably pretty obvious too, but just want to clarify because I'm going to bring all this information back to my unit. So this that we're talking about today only affects those that were deployed, not any other era. I mean, it's within the same era, but only those deployed, correct?
Only those deployed during those.
Okay.
So, you know, yes and no, because there's certainly people, my case definition is for research purposes, you know, and it was always too tight. And there were certainly people that were cleaning out the returning aircrafts, there were people that were making munitions. I mean, there are a lot of people that I see in my clinic that weren't there, good or sick. You don't ignore that, you take care of sick people, so.
Cleaning out aircrafts over there or over
Coming back
here?
when they came back. Yeah, there's quite a bit of toxic exposure at the other end, you know, but not for this thing. That's okay, get answers for them.
As far as for claims and all that, it only applies to those who were over there deployed and within a certain geographical area, which if you have this, I think it will talk about it, or it will tell you where you can look for it. But the laws only cover those deployed. And then for those deployed, it's anybody deployed from August 2nd to those Thursdays.
Okay, and one more question. I'm wondering how it would help most the patients. I'm a registered nurse as well, so I'm a bedside nurse actually. So if the doctor that's taking care of the patient is not picking up, which they might not or probably wouldn't, and now that I have this new information, and they're thinking the doctor's not helping them, how can I help them? Just refer them to the research center?
Get them to the, you can connect your doctor in with the War-Related Illness Injury Study Center, and that's a secondary way that they can, your doctor can get knowledge on what's going on, and a second opinion to help out your doctor and the veteran themselves.
Will you let Layla say something since she's not going to be on the agenda? I think it would be great if you could say what you're doing at Roscam.
That was a good question.
Well, thank you, Nancy, for giving me this opportunity to speak about our research. We are at the Roscam Institute. About pretty much every single person at the Institute is dedicated to working on Gulf War illness. I have a pleasure of having Dr. A. Ghazala down in the audience there. She was my PhD mentor, and I developed mouse models of Gulf War illness under her guidance and Fiona Crawford's guidance, who's unfortunately at a different meeting, couldn't join us, but our heart is here. And I have my team members here, Dr. Keegan, Ross, Sarah, Sandra, Heather, and Utsav. They are back there waiting for you to sign up. We have several studies on Gulf War illness, some dealing at mouse model levels, trying to find treatments that we can move forward in the clinic, and the others are trying to find objective blood tests to help you get a diagnosis. That's been a struggle in the VA system, and we're trying to see if we can find objective blood tests. So I'd be happy to. We are in Sarasota, Florida. Very nice area for you to come and visit. It's the Ross Camp Institute. We have literature back there right by the door if you want to pick up some brochures down there. I'd be happy to answer any questions on basic science research. We've been working on immune aspects, mitochondria, looking at, as we heard about fat from Dr. Klimas, looking at fat metabolism. There are these lipids, there are omega-3, omega-6 that your body largely acquires from your environment, from your diet. We're looking at how it moves through the body and what's the defects in its metabolism, and we're looking at lipid supplement strategies that can correct those defects. We have some interesting data. If you come down and we'll get a lab tour, we can show you those data. And we have an open house coming next week. Next week, November 9th is the day, and it's a Thursday.
So can I ask a question? Can you confirm that you have a blood biomarker for Gulf War illness?
I cannot confirm, but we have some pilot studies that suggest, thanks to Nancy's samples that she provided us through her studies and the GWI consortium, Kimberly Sullivan, we've been looking at omega-3, omega-6 patterns in the blood, in the lipids that are attached to the lipoprotein particles that, there are risk factors for Alzheimer's disease if they change, and also for cardiovascular disease. So we're finding some patterns. We need larger samples. Thanks, Jim, for sending me the samples, so that we need to confirm that.
So these are evidence of mitochondrial dysfunction, mitochondria being the energy factories in your body?
I think these do indicate that there is a communication between peroxisomes that are also involved in fat metabolism and mitochondria. It looks like that the communication between these two cellular organelles might be disrupted. We have to do more conclusive studies for that.
I had somebody who asked me a question earlier about skin problems, and I didn't know if she wanted me to answer that or if she's walking out. But she was asking how can the doctors help out with their skin problems with the veterans. And first of all, the caregivers need to make sure they document within the records that they have the skin issues. First, you have to take photographic evidence of the skin issues that they have, and then make sure you put down how much of either the exposed area of the skin, especially if it's on their arms or forearms and that's affected by the skin issues, whether it's rash or not. Second, it's a clinical diagnosis, which means you have to make sure you put down the different tests that you ran to try and diagnose the skin condition. If you can't diagnose it, just put down that it's like dermatitis of unknown origins, eczema of unknown origins, and that the veteran, they can bring in the research, like Dr. Durst's research, and the doctor can put down that nexus statement, but the veteran can also use that fact of the diagnosis and the thing, but the doctor can say that according to the VA's own research that the skin condition can be secondary or relate to their service in the Gulf War, and that without mere speculation that it's hard to determine what exposures could have caused it, and according to the IOM's volume 10, something like that, but they should work with the service officer then on how to do a statement on that. You don't have to have proof that it's in the record. I'll talk about that a little bit later. But the main thing for providers and caregivers is you document what's going on, and you document the tests that you did to rule out anything, and to come up with what it is. Okay. And And that's the key on this. The veterans need to come in and just get the documentations and the records and get the documentations and tests that go on, and then work with their service officers. That's the key on all of this.
Thank you. I'm a military and Army retiree after 30 years, and I now volunteer as a VSO with the Disabled American Veterans. And it does seem to me that the presentations I saw this afternoon literally could have been labeled service members and civilians probably, who served in LSA Anaconda / Balad Air Base for more than 30 days. Because we see so much with the open burn pits that were in particularly that specific location, the syndromes, and I know that's Gulf War syndrome, but it seems that the studies are all 90-91, and I say that with concern, being that the VA, quite frankly, is usually trying to figure out how to limit cost to themselves. So are there studies underway that they're trying to move? I know right now the VA is just saying anybody who has served after 1991 and on, but the exposure is a lot of it, frankly, is quite, maybe not so much the exposure, because I don't know about the difference between oil burning, but I do know, how bad the open burn pits, the acres of it, and all the solvents poured on it, and the medical waste being burned, and being stationed there for over 300 days, and being ones of tens of thousands of veterans and civilians who were there that were exposed to and have all kinds of problems that might end up being Gulf War. But I don't know if there's anything going forward to try to bring that group into any of the studies, because then it kind of seals the fate. I mean, it basically brings it home is what I'm trying to say.
There are some studies going on, but the burn pit registries and the environmental exposure letters and that for the OEF veterans is much more liberal than the one that is for Desert Storm veterans. You got to look at that letter that's in the M21 manual. You have access to that and all that. That's more liberal. There are some studies out there. I just used the research that was done in 2004 or 5. I can't remember the exact date. I know when it was done and when it was released. And it's in the 2000 volume 8. It's volume 6 or volume 8 of the Gulf War thing on the GI problems that the OEF veterans had. I use that in a claim for a veteran that's served in Afghanistan. So there are studies out there on the newer veterans. Okay.
I think that Dr. Rome is still here in the back too, and he's in leadership in environmental medicine in the VA. But it all usually starts with epidemiology studies to prove that there's really something there, as you were saying, and maybe you could speak to this. And then once you can show overlapping syndromic, then you can start generalizing from one set of research into another space. So you're right, drawing a cut line in a certain day, month, year in 1991 is kind of nuts. The exposures didn't end there by any stretch. But there is something political here, which is that these incredible advocates, someone in this room, go to Congress and say, we served and now we're sick. You need to do something. And Congress very tightly wrote their language to Gulf War illness from the Gulf War. So
remember that anyone who served for the OIF veterans and all that, okay, the presumptives, chronic fatigue, IBS, chronic multi-symptom illnesses, undiagnosed illnesses, all apply to OIF veterans. They don't apply to OEF veterans, just OIF veterans. But if you have illnesses that you believe are caused by your exposure, such as asthma and that started shortly after you got back, okay, those you can still file for due to your exposures in your deployments, due to burn pits and stuff like that. Okay, And I've seen the new training for the examiners and all that, and they use asthma as an example. And the examiner's training is pretty good.
Thank you. I'm finding a lot more of this happening now. I go over to Eastern Florida State College, and they have a huge veteran population over there. And I'm seeing a lot of what I was reflected in what their complaints are. Now they've been back a few years, which is exactly what you started this afternoon. You know, they get back for a while, you know, and they're starting to realize that, boy, they're not as healthy as they thought. They thought they would just, you know, shrug it off and the rest of it. So it does seem to be history repeating itself.
Yeah, but I think you also see is that sometimes the veterans themselves don't write a statement about their symptomologies, what's going on. They don't do follow through on that. They don't get the proper documentations in their files, and that's what's happening. And I've done claims all over this nation in the last, in my lifetime here. And I know St. Pete is a very hard regional office to get these types of claims through.
Well, they don't, now the VA just ships them out, they queue them up.
I know how they do it, yeah. But this was a hard VA in a long time. They used to ship a lot of their snowbird claims up into Kansas years ago. That I know.
I think a little bit of clarification with the OIF vets. Ma'am, are those with OIF vets? I'm kind of clarifying. There was a difference, I think, on the oil field fires versus the burn pits. When the oil fires were going on, it drifted through the whole Saudi Peninsula. And, you know, we rubbed forward by the border. The ones that went through Marines, they were coated in oil. You know, their skin, their uniforms, and it went down because we were at the border, came down to us, then we moved back to KKMC a couple of days later. You know, the air quality was terrible, okay? And so the burn pits, you know, wasn't there for the burn pits, but I think they were more localized and didn't spread as much, and you didn't, I don't think you had as much of the low-level, consistent, probably sarin exposure that we had. They had IEDs with, you know, the old sarin, and they were taken care of in OIF. And our people have not been that were at Coliseum. As far as, I think they got their Purple Hearts. There's been none of that for the Gulf War vets at Coliseum. So there's some subtle differences. So, you know, I think we will see differences. The value of concentrating on the 9091 is if we get biomarkers, we'll be quicker to be able to turn around and take those that only served in Iraq for, you know, Operation Iraqi Freedom, because we'll have the biomarkers based on our long and troubling experience. And I think that's the value of limiting and constricting it to the time of the Desert Storm. Because you can't, if you make it too wide, I think you're going to end up with more mass juggling of biomarkers that may differ. And the other thing I caution is providers, I think, like a nurse, and think about our clinical care. I just want to mention, you need to put down the unit and the service that the person served in the history of physical. Okay? If they were Marines, what was their unit? Because we can still get that data from DOD. Okay? And we need to do that. The other thing we need to do is the unit, the location, and we have to be sure when we go to the OIF population to be sure that they may say, well, I served in OIF most currently, but they may have been in Desert Storm too. So we have to be careful on some of the data collection going forward.
Because you're talking, many people are talking about the risks, the exposures and so on. So it's been 26 years. How do you deal with, scientifically, how do you handle knowing which of these risks are meaningful or which ones do weight? What's the procedure?
Yeah, this is not to be cute and shy about it, but it is the job of the epidemiologist to try and sort through all of the relevant exposures as a way of trying to answer the question that's been posed. So if you have a group of veterans who have respiratory problems like asthma or chronic respiratory ailments, you're trying to understand what differentiates their exposure from some sort of a control group. And if you've got mixed exposure where you could be oil field plus very severe dust storms plus who knows what else, some sort of acid waste or something like that, you try and parse out every single one of those. But in addition to that, you also want to take a look and see if there's an interactive effect of smoking and dust exposure, smoking and oil field burning, and those kinds of things are always being looked at in the data as a way of trying to answer this question. So you start off with a couple of questions that really motivate you to create a registry, for example, but the follow-through and the professional analysis of data and evidence is a much more systematic process, not haphazard, but it basically runs through whatever specific data you've collected about what the troops' exposures were, even if it's just simply a voluntary set of recollections about what they dealt with or what their unit dealt with. That's better than having to try and make something up from whole cloth. And that's, I think, the reason why we need to try and focus on getting large-scale data sets and then being able to analyze them using full medical records, which is what the example I shared with you earlier in the day by Dr. Rushecki, because she had all of those clinical interactions between the physicians and the people in the Coast Guard. She didn't have to get something specific from memory or anything like that. She had them all the way through their time in service. So that's a major plus in her research. Yes, sir.
Talking about exposures, one thing, you know, like myself, I was on one of the NBC teams. I was one of the guys that would go around whenever our alarms went off, pull out the 256 kit and start doing our little chemical experiments in the air to try to figure out what we were exposed to. Now, you know, alarms went off quite a bit out there. And when I did some of the tests, one of the things that would come back was a lot of times they would not come back clear as negative. However, they would come back as inconsistent. It was like, okay, there's something in the air, but it is not, it is not in the chart. We don't have a color for this. We don't have, we don't know what it is. Now, the thing is, once we got ready to come back home, what happened with all those NBC records? They were thrown into the fire pits. When we got ready to come back home, they took all those reports, documents, and everything, they were just chucked right into the fire pits. So that's, you're talking about thousands and thousands of records just destroyed.